Hello.
Dr. Jayesh, sir, and thanks for your presence. I also have Dr. Bikramjit Basu here. We will actually start with your presentation, sir. So you can just load in your slide and then we can.
Oh, great. Thank you. All right. Thank you. Thank you very much, Shibu. And it's good to be with you, Vikramjit, again. And what I'll talk about is to highlight a few things that we are doing here. As stated in the title, so we are looking at materials that are resorbable. Right? So that's one important point, that materials are resorbable. They don't stay on forever. And they are nanostructured, and these are for bone reconstruction, and they are customizable by 3D printing. So resorbable nanostructured scaffolds for bone reconstructions, customizable by 3D gel printing is the main theme of what I will share with you in the next 15 minutes or so. So this is work that my students have done, particularly the work of Deepak, who just finished his PhD and is currently doing a postdoc in the US, and several others, Kunal and Siddharth, and so on. And we've had many collaborators, particularly from the ACTREC and TMC, Tata Memorial Hospital group. And the one that I will be talking about is the one that is useful for making bone constructs. So that's the point of this presentation. However, in our group at IIT Bombay, we look at a variety of nanostructured materials for regenerative surgery. So, for example, we make hollow fiber membranes suitable for hemodialysis, and these we convert into various things, various types of mass exchangers, in particular hollow fiber bioreactors, in which one can have cells either on the inside or the outside of these fibers. And some of these are made by 3D printing, some of them are made by other fabrication techniques. And these have been used in hemodialysis, which are passive devices. We are also working on bioartificial kidneys to suit hemodialysis better. And here is where we grow cells. We've already developed a bioartificial pancreas where islet cells are entrapped within these fibers, and these fibers, hollow fibers, can be implanted inside the peritoneal cavity. Here is an animal experiment that we did in a mouse model, and which worked great for about 28 days or 30 days, for which longest duration we got ethics permission for. And this has now been in the process of being transferred to a startup which is going to develop and take this further. And another application of this is the bioartificial liver, where we grow hepatocytes on one side and then flow blood through this. And so this is like a dialysis machine, but for the liver. So this is one whole series of technologies that came about by virtue of the hollow fiber membrane. Another area that we've been working on, which is at the top right, is our closure devices for holes in hearts. So this is a PDA, or patent ductus arteriosus, and an ASD device, arterial septal defect devices, which are developmental defects in the heart which need to be closed. And we've developed some umbrella devices, partially based on metal, partially based on polymers. We are now moving towards a total polymer design, and these are delivered transcatheterally into the heart, so as to close those holes. Another area that we are working on, which is on the left middle, is the area of nanomedicines, particularly those arising in systems of medicine, across all the systems of medicine. So we work with allopathic system, wherein we've made a nano carboplatin, which has gone for first in human trials and was effective in delivering carboplatin to the retina, where retinoblastomas are a major problem, particularly in pediatric patients. We also have been looking at similar nanoparticles which arise in alternate medicinal systems such as Ayurveda and homeopathy. Has been highly cited and draws a lot of attention even today. The another area which is of more relevance to today's conference is the guided bone regeneration membrane, and these are membranes which are made by electrospinning, sometimes using a 3D printing head in a bioprinter, and they are very effective in growing cells in plane, prevent cells from going across it, but in plane there is good growth, and these are useful in several regenerative medicine applications, particularly for bone tissue engineering. So this area of bone tissue engineering, of course, is an area that's important. It's been used by using autografts or sometimes allografts or sometimes even xenografts from the patient's own body, often by taking out bone from other sites, requiring a secondary surgery. And this bone loss is something that needs a lot of repair. So the solution which we have is a material that is biodegradable, can bear a small amount of load, enough for the body to heal itself over a period of time. And as the body heals itself by laying down bone, which happens throughout life, although the rates may vary depending on age and condition of the patient. But these are techniques by which the body can be encouraged to lay down its own bone. While it does so, it consumes these materials, these external scaffolds that we put. These are made out of a variety of materials which I shall mention as we go ahead, and they are 3D printed into custom shapes or into standard shapes. Shapes such as the cylindrical one shown here are also useful because they show the graded porosity that natural bones have, which can be done by custom algorithms to print this in a suitable manner. So this area of bone tissue engineering is a very fertile area for 3D printing applications. There are numerous clinical applications, of course. Dental and orthopedic are there. So a typical example is a periodontal cyst. Many orthopedic applications even socket dental ridge augmentation by putting into socket. So numerous applications are there across many fields of medicine. The anatomy of bone is complex, and attempts to replicate the entire bone anatomy as well as the physiology and the cell types remains a challenge. With today's bioprinters, we are reaching some level of achievement, but I think we are still some ways away in duplicating the entire structure. However, major advances have been made, and those advances are to replicate the anatomical detail, both in terms of the external shape, the internal architecture, and the nanoporosity, right down to trying to mimic the collagen fibers that are present internally within the system. And we'll see some of that in the gel structures that we make. These gel structures that we make are modified collagen. They are in fact gelatin, which turns out to be a low cost but very effective way of providing the biological scaffold into which natural cells can grow. If needed, these can be augmented with bioprinting with additional cells, but we have often found that it is not necessary to do that. Natural bone provides enough osteoclasts to populate this structure and close the wound effectively. So a typical bone scaffold has numerous properties that it has to satisfy. There are biological properties, and these biological properties include biocompatibility and non-toxicity and so on. Bioresorbability is an important aspect. Today's state of the art or today's standard of care often uses metal-based, including titanium and its special alloys, chrome cobalt, and even stainless steel, because it provides the necessary strength, but that's also a disadvantage by virtue of stress shielding. And there are attempts to use non-biodegradable polymers as well to try and match the stress and avoid the problems of stress shielding. but one has to, ideally one needs one that does not remain behind. A bone scaffold should not remain behind, and that's the idea of the bioresorbable materials that we are developing. Second important aspect of bone scaffolds are the structural features, the mechanical stability, and the kind of structure, high porosity needed, the customized shape, interconnected pores. So these are structural features at a gross level and at a microscopic level and at a nanoscopic level. There are another set of challenges that need to be met. The materials used have been several. Metals have been used extensively. Ceramics have been used. Polymers also have been used. So the real challenge is in combining at least two of these together to be able to provide all the functionality, the structural and the biological functionality to make an efficient bone scaffold. And the fabrication techniques are extremely important, and that's where 3D printing plays an important role. There are other techniques as well. So in general, additive manufacturing techniques have become extremely important, particularly for customized bone defects, but also for making standard shapes with very complex internal geometries. It's always useful to have standard shapes in the surgeon's repertoire for a quick repair without relying on an external fabrication bureau. So the aim of all this is to provide good cell viability, to provide cell attachments. If stem cells are present, and they always are, or externally added, osteogenic differentiation, good cell proliferation. The mechanical properties include load-bearing ability, the integration into the host, and the vascularization, which eventually provides healthy bone subsequent to the implant getting degenerated or resorbed, as is the intention of this method. Listed here are some of the target specifications. There are numerous specifications which I will not read out, which include porosity, the ability to degrade over and here there are two requirements: a short degradation time as well as a long degradation time, depending on the area, the kind of strength needed, cancellous or cortical bone, and the types of porosities ranging from micro to nano. The clinical needs include various customized shapes and the ability to be osteoconductive or preferably osteoinductive, and to have a controlled degradation over a period of time. So we need, in short, the overall needs that we have are patient-specific 3D bone grafts to fit into voids of complex shapes, to include porous structures, and to mimic the graded porosity, to mimic the biology, including the biocompatibility, the osteoinductive nature, osteoconductive nature, and so on. These scaffolds should be able to host cells, although opinion is divided whether it is good to add cells externally or it is much simpler for the surgeon to use a bare bioactive scaffold without cells. And we prefer the latter at the moment, simply because of translation considerations where cell therapy kind of approvals would not be needed from the drug controller with scaffolds that are free of any cellular constructs. The load bearing and biodegradability have to be matched well. And lastly, the turnaround time for a custom built scaffold also has to be kept in mind. On this, numerous such bone regenerative medicine products have been developed in our lab. All of these are resorbable based on new materials. In many cases, the fabrication techniques are also unique, and I'll mention one in the next few minutes. We have a spongy bone graft, which is extremely osteoconductive. It's a bit osteoinductive as well, and these are used where load bearing is not required. This is a bone void filler essentially, and this can also be 3D printed, which is what I'll show you in a few minutes. This has excellent performance. You can see in a micro CT experiment where the standard of care, which is no graft at all, shows bone that is being laid and remodeled, but still being a critical defect. The body cannot bridge the defect, whereas the treated side builds up bone to a good density. We also make load-bearing structures such as bone screws, which are based on silk fibroin with nanofillers of magnesium oxide, and these are now reaching the preclinical trial. They show biodegradability, which can be tuned over a period of several months to a year or so, which is more than adequate for many fixation applications, particularly soft to hard tissue fixation, such as in tendon and ligament repair. Many of these can be 3D printed into structures such as seen here. Here is part of a chin bone that has to be replaced in a cancer patient, and we have matched this, and now we are awaiting ethical permission to try these in human subjects. And many long bone applications such as these, where there is a gap defect which needs to be filled with a bone, and these are now we have ethical permission to do these in animals, and we are doing this. These are all resorbable over a period of several months, and these trials will now help us move it into human clinical trials. The first product, the bone void filler here, which we have shown, has received DCGI approval and is now undergone a successful pilot trial at AIIMS New Delhi. So typical workflow in such applications begins with a CT scan, the defect isolation, then building the construct, and then 3D printing it, filling it with more osteoconductive or osteoinductive material, and that's what we are doing in this animal trial, which we are about to begin, in which the long bone will have a defect which is going to be filled in. So some of these the constituent materials which go in here have been shown in these micro-CT animal experiments, and also in some rat calvaria experiments, which shows that these materials are very osteoinductive and can be can seal bone voids very efficiently. And the micro-CT evaluation, which I already mentioned briefly, shows that the bone is laid down by the and to a very high bone mineral density as compared to the standard of care, which is sham, particularly in critical size defect. And this has also come out in our human trials, which we are in the process now of publishing. On the biological side, cell attachment in these materials is excellent. The mineralization and osteocalcin labeling shows good mineralization, and therefore some of the efforts now are towards matching tubercular structure and the porosity gradients that are present in the system. The idea is to be able to provide this anatomical detail at a micro level and eventually at a nano level by virtue of how the gel deposits itself. And we do this by a custom 3D printer that we have built. The idea is to have hard plus soft tissue, and the soft tissue is printed as a gel. This gel is cryogenically printed, and this cryogenic gel is then subsequently processed by freeze drying to provide the nanostructure, and the gel is printed or coated into another 3D structure which has been previously printed, into which there is which provides the necessary strength. So here are some details. There's a cold plate onto which this is done, and the entire 3D printing head is kept under cryogenic temperature, so that the printed sample retains its structural integrity as a gel, which is hard now. Subsequent freeze drying then provides the necessary porosity into which the osteoblasts can travel. The nanostructure comes about by the subsequent step of lyophilization once the cold plate receives the sample, and this provides us the ability to then print these complex structures, and we can see the results here of how these structures are in an electron microscopic view, which shows the scaffold and then the gel that fills this in, and eventually at a microscopic level the highest degree of porosity based on the gels that we have printed. One advantage of these scaffolds is that they are spongy. They have ability to recover, after a deformation, and this is important in applications where the access to the void is through a very narrow opening. These scaffolds show good activity, and the workflow solutions are such that we are now able to cater to customized defects as well. In order to get uh, good structure, special algorithms have been developed in which the graded porosity from external, the dense layer on the outside, to a porous layer, and in fact a hollow layer at the center, have been achieved by having some algorithms which drive the 3D printer, and we are able to then build these scaffolds which are customized to particular applications. So the achievements really here have been to develop these algorithms on a customized 3D printer to be able to provide this gradient porosity. These algorithms are suitable for a variety of shapes, ranging from block type shapes to shapes re-entrant surfaces, as well as complex geometries of this sort. And these have, of course, been proven in the lab, but now need to be proven in first in animal, in preclinical studies, which we are beginning next week, as a matter of fact, and subsequently, of course, in humans. And just to recollect, there is a hard tissue here, which is a longer degrading time, provides structural stability and some degree of mechanical strength, and there is a soft tissue. So both hard plus soft tissue are modeled by a scaffold in here and provide a high degree of regenerative growth in the lab. We are now going to test this in a preclinical model, and then see how well it works there in order to apply for drug controller permission for a human trial. So these are achievements that have happened over several years, in fact over a decade, and I'm grateful to the funding agencies and the students who worked on this. So let me stop here and be happy to take comments and questions if any. Thank you.
See my screen?
Yeah. Yes, doctor, please. Yeah, perfect.
Yeah. So, good morning, everybody. I think that these particular presentations I might have given at this forum or many other forum, but still, for the benefit of the readers, I'm going through some of the key slides to highlight our work on 3D printing and bioprinting of implantable biomaterials, challenges in clinical translation. So this is the plan of these presentations, which will include little background and relevance, followed by 3D binderjet 3D printing that we have been doing for quite some time now on metallic systems as well as ceramic systems, and third. That I would like to highlight on the 3D extrusion printing of the GELMA, gelatin methacrylate, and anohydroxyapatite. So 3D printing, I will skip the slides because Professor Jais Pellare has mentioned that what is the relevance, but just to remind you that in these head-to-toe applications of the different for the reconstruction and replacement of different parts in the body, 3D printing has specific advantage in terms of the providing the patient-specific implants. And it is valued at 1.2 billion US dollar at a compound annual growth rate of 29% in India. As I said, patient-specific implants, freedom of design, improved functionality, enhanced biocompatibility. These are the major things. These are the major attributes of this 3D printing in general. Now, if we look at an Indian market, almost like 80% of these implants and biometers which are used in India, these are all imported from the Western countries as well as Europe. This means that many of the implants often are not specific to the Asian or Indian population in this particular. And this mismatch often leads to this, either implant failure or not the optimal performance, clinical performance of these implants. And so if we and if we look at these values, some of the market values, Indian orthopedic device market is currently valued at 8.2 billion US dollar and growing at 30% per year. And in terms of numbers, if you see, almost like 34,500 clinical case of total knee, and 3,600 is total hip replacement that is recorded in the in the Indian registry. Okay, so in these particular presentations, I'll be mostly concentrating on this binder jet 3D printing that is in the right hand corner, which has been mentioned here. So here the binder formulation is important. At the same time, different other printing parameters are also equally important. This has been shown here more elaborately. What happens during binder jet 3D printing, individual layer is getting displaced and it interacts with this binder. And this specially formulated binder, when it penetrates into the build bed, these interactions is governed by several parameters. Like in terms of the binder properties, viscosity, surface tension, pH, etc. In kinds of build parameters, the layer thickness, printing speed, all this. And on a more fundamental basis, some of the dimensionless numbers like Orthodontist number and Reynolds number and their combination defines that whether any given binder is essentially printable fluid or represents the printability or not. Now, titanium 6 aluminum 4 vanadium, this is one of the metallic system that we have worked. What we have done, we have mixed these powders with this initiator, and in the binder contains a monomer acrylamide and accelerator. Now, this binder solution, when it interacts with this powder, we expect the in situ polymerization takes place, and in situ polymerization is also tracked by DWS technique, and there is also capillary infiltration. We develop some models, particularly Wasburns model, and modify the Wasburns model to quantitatively analyze this binder infiltration into the powder bed. Right. So if you look at this, how this, I don't know whether you are able to see this movie, that how this binders is interacting with this powder bed, and then different dimensionless numbers based on this very high throughput cytography measurements of this binder particle distributions and so on. We have calculated Orthodontist number, Reynolds number, and Weber number. And what we found out that in terms of this Orthodontist number, Reynolds number, this particular binder formulation that we have, that actually falls in this printable fluid region. Whereas if you use the deionized water in this particular case, then it is not essentially at this printable fluid region. So which makes us to validate further in terms of this properties of this particular binder formulation, and then how that binder, when it is interacting with this 3D titanium 6 aluminum 4 vanadium powder particles, is able to help us to obtain the robust microstructure. Now, the as printed microstructure where volume fraction is 52%, when we sinter it, then certainly volume fraction of the porosity decreases to 28%. Interconnectivity of the pores remains almost a similar level, that is 98%. And if you look at the number average pore diameter is around 8.9 micrometer. One of the main thing of the 3D printed structure is this: what is the strength reliability? Because it is interconnected porous, and also there's a reasonably high fraction of the porosity here. What we get in these particular cases of 3D printed TI6L4V, here this viable modulus is 8.1. And 8.1 viable modulus is a very respectable number, particularly for the porous scaffolds. Now, in terms of the biocompatibility, we have used different cell lines like either fibroblast cells or osteoblast cells, MC3T3, and in all these cases, we have found whether up to when cells are grown up to 7 days in culture, these 3D printed structures, they encourage the proliferation of this type of cells in a manner which is even better than that of the control or metallurgically processed TI6L4V. So this work is patented. Now, one of the things that what we have taken it further, we have used this metal 3D printing and trying to see that whether metal 3D printing can be used to produce a femoral stem prototype. So what we have done, we have taken the design from the Orthotech India Private Limited, because we are working very closely with Orthotech, who happens to be the comp which happens to sponsor this particular symposium or online workshop as well. And when we have done this femoral stem prototype, we have found out that surface roughness of this 3D printed stem is less than 1 micron. In broach, typically orthopedic surgeons use to identify the femoral cavity during the surgical operations. This broach also we have printed, and then it is having a very good, manufacturability that has been established in the metal 3D printing. Now, coming to the more ceramic binder jet printing, we have investigated, or we have more explored in a collaboration with Germany, that how this strontium substituted magnesium phosphate can be printed. So what we have done, we have used two types of post-processing technique. One is a sintering, one is a chemical conversion, as mentioned here. Now, depending on this, either sintering or chemical conversion, we are able to get farringtonite as well as struvite as the phases which are present after the post-processing. Now, importantly, when materials are printed and converted, we have found their pore size distribution actually shows more like log normal type of distribution. With printed and converted, their pore diameter is around 30 to 40 microns. Now, in terms of the viable modulus, as I have shown you before, here the viable modulus can go up to 8.89. And if you look at the traditional ceramics and engineering ceramics, their viable modulus can be maximum up to 10. So it behaves like a brittle materials, but also it is not too brittle. So it has a respectable viable modulus value, which essentially represents the strength reliability of this material. In terms of in vitro dissolution, we have done this magnesium phosphate, magnesium strontium phosphate materials, and which shows that when it is little higher strontium content is there, it shows the in vitro dissolution of the strontium-based strontium ions as well. Right. So this work was published in Acta Biomaterialia. Now coming to the 3D bioprinting of this gelatin methacrylate. Now, one of the things that I would like to mention here, there is two concepts. One is the printability, and one is the buildability. A printable ink may not necessarily lead to buildability, because buildability essentially means how the robust structure can be printed using 3D printing technique, and this structure can be built in a freestanding structure without any support, and also the longer the dimension of the structure that you can print without any structural distortion, that will represent a quantitative or qualitative measure of the buildability of this particular ink. So what you see here, it is gelatin methacrylate with methacrylate based bio ink, and then you can see that this material can be printed to a construct of the size of almost like 20 millimeter in length, and then you can see that there is not much visible structural deformation, and then what happens that during the printing there is a continuous in situ cross-linking, but by exposing them to the UV. So so this is like, we have optimized that, printability and flowability of the ink by using different nozzle dimensions, and this is how the structure looks like when different hydroxyapatite amount of hydroxyapatite is added. In terms of biophysical properties, we have done uniaxial compression, enzymatic biodegradation, and swelling analysis. And in most of the cases, we have used some of the theoretical models, trying to see that how this structure, how this property can be modeled using some of the established models from the literature. So you'll see that how different type of structure can be built using either gelatin methacrylate, 15% gelatin methacrylate, and 50% gelatin methacrylate, 1% hydroxyapatite. At this point, I must mention that we have continued this work currently in my group, and then current focus is to use the lower concentration of gelatin methacrylate, because people normally use higher concentration gelatin methacrylate to get good strength, and we are trying to see that how this ink composition can be optimized at the lower percent of gelatin methacrylate, like 7.5% or 5% gelatin methacrylate, and together with PEGTA, that whether we can achieve the properties which is comparable with that what we achieved in the 15% gelatin methacrylate. So we have used 3D printing to develop the clinical models of the defective cranium and trying to identify that what is the cranium defect size for the patients who have undergone decompressive craniectomy to remove the either road traffic injury or brain tumor or stroke. And in this particular case, in one of the index patients, you can see this patient is a very large defect of 110 centimeters square, and which has been reconstructed using the PMMA polymethyl methacrylate bone flaps. Polymethyl methacrylate bone flaps, and during post-operative analysis, we have found out the cranial index of symmetry of 95% could be obtained. So this work received some media attention. So we always meet these clinicians either in a formal and informal meeting. This is one of the national conclave that we organized in the cranioplasty surgery, where we have involved many clinicians, neurosurgeons from different parts of India. So I'd like to. Finally, I would like to acknowledge all the sponsors which have supported our research over last 15 or 16 years in the field of biomaterials and implants. And I deeply appreciate the contributions made by different generation of the students in my group over last 15 or 16 years in the field of biomaterials and implants. Thank you very much.
Any questions from the audience can be addressed towards the end with all these presentations being done with. Thank you so much, Dr. Bikramjit, for your insights on the subject. We are also taking inputs from some of the medical associations also. We have key people from AOMSI, that is from Association of Oral Maxillofacial Surgeons Association, who would also want to learn and understand in terms of various materials, doctor, that we can look at in terms of mandible reconstruction and likewise. So, doctor, is there anything that we can actually share in terms of clinically proven materials immediately in terms of for these requirements? In case I'm talking about orbital floor, in recent times we have seen with mucormycosis. Is there anything that we can look at except for the plates like the titanium and the PEEK material which is used? Is there anything else beyond this that we can look at as an option?
It all depends on what kind of materials and what is the applications, more specific applications they have in mind. So I'll be very happy to talk to them over email or some separate meeting.
Okay.
So I think we can move on to the next speaker then.
Yeah. So may I now introduce Dr. Falguni Pati, who is the associate professor with a department on biomedical engineering from IIT Hyderabad. Doctor, are you there? You're live? You can get your camera.
Yes, I'm here.
Yeah.
Okay. Am I audible?
Yeah, you're audible.
Okay, thank you. Good morning, everyone. Thank you very much, Dr. Siru, for providing the opportunity to present our work. So today I'm going to talk about one of such work that has reached to a certain stage that we are now going into preclinical and clinical studies. So the topic is 3D bioprinting of corneal matrix with a biomimetic hydrogel. So as you see, cornea is the outermost layer of our eye, that is the black part. In certain cases, it can be some other color also, but it is a transparent tissue, and it is almost like 11 to 12 of diameter. The important thing is it is an avascular tissue, and it acts as a barrier and protects the inner structure of the tissue of the eye, and it has a very good or superior reflective surface, so it focuses the light to the retina. So that's why how we can able to see this. But important thing is the transparent and avascular tissue. So this is here. If you see here, then this is the part of the cornea, and then it has, if further in the ultrastructure, it has further it can be divided into different layers. Like the topmost layer is the epithelium, where the epithelial cells are present mostly, and then the major part of the cornea consists of stroma. That is almost like 80 to 90% of the cornea consists of stroma, and there the resident cells are keratocytes. And the innermost is the endothelium, where the endothelial cells are present, and they maintain the osmotic balance between the inner cornea and the inner structure. As I already mentioned, cornea is a transparent tissue, and the anatomic feature is it composed of a tear film. So all the time a tear flushes through the cornea, and the cornea is never get dried because of the tear film present. And the hydration of the cornea is very important factor to maintain the transparency of the cornea. And why it is the cornea is transparent? Because of the lamellar arrangement of the collagen fibers that is present within the cornea. So every layer cornea is either collagen is present in a lamellar fashion or in a parallel order, and there is a regular lattice structure with, and due to these features, cornea is a transparent tissue. Now why we need a corneal graft? If you see, corneal blindness is one of the major cause of global blindness. It is the fourth leading cause, and in India about 6.8 million people are there who are affected because of various reasons, but who end up in the corneal blindness. And the gold standard is the transplantation of corneal graft from cadaveric cornea, or because many of the patients who are placed to donate cornea, so from the eye bank, that cornea, that donated cornea, that is being used for as a transplant. So that is the only surgery available, that is the only treatment available in case of many of these cases where corneal blindness occurs. But if you see, only 1 in 70 in the world they get the transplant, and many of these, and almost like 69 in 70, so they are waiting for a corneal transplant, and almost this is the number, 12.7 million people are waiting for a corneal transplantation. So we need to come up with a solution where we can bridge the gap between this huge skewed demand and supply of corneal graft. So in this study, actually what we have done, we have developed a hydrogel that is from a discarded human cornea, and we hope that, and then we do a series of studies to understand whether the physical properties of this hydrogel, also the biological properties, so that we can finally, our interest is to 3D bioprint a corneal stroma basically. So these some studies, I am showing you some of the data of the studies. So we have discarded human cornea, that is from the eye bank. Those are not certified for transplants. So not get human cornea we have used here. Also, we have collected bovine corneas, to show that also to study whether the potential of these two sources. Then we have done a process called dissolution, when we have removed all the cells, and then we got a dissolution extracellular matrix from cornea. Now, if you see here in histology, in the native cornea, it's a typical corneal structure, stromal structure, or the corneal structure is present, but in case of dissolution cornea, the structure is lost, but most importantly, all the cells are gone. So that is our interest, because we want only the matrix, and in the matrix, most of the bioactive factors that is present in cornea, those things are there. Also, the composition is very similar to the native cornea. So we wanted to use this dissolution cornea matrix for our further work. And then we have also characterized them by various ways, like one such thing is the identification or quantification of the DNA present. By DNA, we are trying to understand what is the level of cellular content that is present, or the resident cells that is present. So in our case, we have clearly see that almost like more than 97% of this DNA is gone. That means, so we have successfully removed the cells. Also, you can see a good amount of collagen and GAG that is present. Those are the ECM components that is present, and this is for both this thing for both human dissolution cornea matrix, and also for bovine dissolved cornea matrix. The next thing also we studied, because our interest is to bioprint them, so rheological characterization is an important step towards that. So where we have characterized the hydrogel prepared from this dissolved cornea matrix, and we can see that both these hydrogel they behave like a shear thinning material, and that is required for bioprinting, especially for extrusion based bioprinting. Then also we have seen them that this dissolved cornea matrix can gillette. That means we can get a solution form at below 15 degrees centigrade, but when we adjust the pH to 37, then you see the modulus is in. That means it is going towards this gel state. So that's the salt to gel. The transition can happen over when we incubate them at 37 degrees centigrade over a period of 30 minutes or 45 minutes. So same way we have also the viscosity of both these curves at different percentage of this we have seen. But for our study we have selected 2% because 3% is very highly viscous, and it is like we cannot control the gyration of this thing. It gillette very fast. So that's why we have chosen 2% for our further studies. And this is the shear recovery of this hydrogen, because in case of bioprinting, if you see that because it witnesses a shear stress when it is going through the nozzle, and then when it comes out it is again. So it's a high shear stress, and then again it's a low shear stress. So that's what we have done here. You see, when we applied shear, that then viscosity comes down again. When we have removed the shear, then the rate comes. It's almost like more than 90% recovery. You can see. They have done various other characterizations like the physical characterization, the porosity. It has very good porosity. Also, another interesting thing that we have noticed that this hydrogel, when it gel, then if we incubate them in PBS, then it doesn't swell. But it diswell. That means it has water. That water is going out. So that's why we need to consider this when we go for bioprinting. Then we have done a series of biological characterization like this, the cell viability. Here all the green dots are the live cells, and there are some red dots, those are the live cells. Almost like we have seen more than 80 to 85% cells are viable over a period of 14 days. Also we have seen case 67, so hereby we can understand what is the proliferating cells. We found that at the beginning, like at day 4, the cells are mostly proliferating, but when over the time at 14 days, the cells are not proliferating, and that is typically the behavior of keratocytes. These are human keratocytes that we have isolated, and we have cultured them over the hydrogel. The same with the HDCM also, we have observed the cell thing, and this is the Ki67 positive assay. So we have found that till day 4, the the proliferation rate was very much there, but over a period of like 14 days, the proliferation capacity that comes down. Then we have did one assay where we're trying to understand. Suppose if we create a wound, whether these keratocytes they are able to bridge that gap or not. So that is a standard wounding assay where in a standard confluent plate, a wound is created by pipette, and then it is studied how these cells can bridge that gap. But our interest is to understand whether if we put the hydrogen between gap, whether the cells they are able to bridge the gap or not. So that is whether the cells can able to migrate through the hydrogel or not. So that's what we see in that 30 hours. So in both cases, without hydrogen and hydrogen, both cases they are able to bridge the gap. But here we are not able to understand whether the cells are migrating below the hydrogel, over the hydrogel, through the hydrogel. So that's why we have done a depth-dependent confocal microscopy where you have this is the different colors are given for deep cells are present at different layer, different height, and our hydrogel is almost like 300 micron. So what we see that cells are mostly migrating at this height. So at 200 to 250 micron, the cells are mostly migrating. So that means cells are migrating to the hydrogel. So this hydrogel is highly supportive towards cell viability. We have confirmed cell proliferation and cell migration. And also another striking feature we have observed that keratocytes, when you culture in vitro, like in a tissue culture plate, they often lose their phenotype. So they differentiate towards myofibrils. That means that the contractile cells, they produce a lot of collagen, and this myofibrils are one of the cells. From literature we can understand that they create the scar tissue. That means when the cells, if the keratocyte in an injury, when they become myofibrous, then they produce this scar tissue. So in our study, we found that when we use DCM, like the dissolved cornea matrix, as a coating material for the culture of this or expansion of this keratinocytes, they are not becoming myofibroblast. They are mostly they are maintaining this fibroblastic morphology over a period of 14 days. We have studied. Another thing, then also we have studied the gene expression profile of this study, and keratin sulfate is a protein that is present in the cornea tissue. That's the major cornea matrix protein, and we found that so the gene is responsible for this protein thing. That is also expressed very high within our DCM hydrogel, but not. And we have we have done the comparison with the standard material like collagen, and we found that this DCM hydrogel, the cells present in the DCM hydrogel, they produce very less alpha SMA, that is the smooth muscle actin. So that's also an indication if the cells are going towards myofibroblast, they will produce more like collagen 1 and alpha SMA and less keratin sulfate. And our immunohistochemistry study also support the same thing. When the cells are encapsulated within this distributed cornea matrix area, they produce more keratin sulfate, less collagen alpha and this thing. And this is also by understanding the construct diameter also you can see the same thing. If the cells are going towards myofibroblast, they will construct the matrix more, or the matrix will be reduced. But in case of DCM, the reduction is not much, maybe around 5-10%, not more than that. But in case of collagen, the reduction is huge. So that means in this case, the cells are mostly going towards myofibroblast. The next thing then we have done, we have studied the in vivo, because before going forward with the 3D bioprinting, where our interest is to see whether this hydrogel that can support in vivo wound healing or tissue regeneration or not. So that's what we have done. We have selected a injury model, a surgical injury model on rabbit cornea, because rabbit cornea, the diameter is almost very close to the human cornea. So that's why we have chosen rabbit cornea as a model for our study. What we have done, we have created a defect in the corneal. So we have removed the epithelium. Also, a part of the stromal is removed by surgical method, and then we put our hydrogel in this gap, and then we ask this question whether this hydrogel is able to support this corneal matrix regeneration and also reepithelialization. So both these things, and this is some pictures from our in vivo study, and this is the fluorescence staining assay over a period of 90 days for all the different groups. We have studied into 4 different groups, like in our case, human cornea tissue matrix, bovine distributed cornea matrix as a control, where we have not used any hydrogel, it is just a surgical replacement model, and also we have a standard material like collagen. And this is the pre-op. If you see fluorescence stain, basically, if the epithelium is not reepithelialized or the epithelium is not grown properly, then fluorescence it will stain that part. So in case of pre-op, very less staining because the epithelium is still present. And at 7th day, if you see, in case of collagen and control, the epithelium is not grown properly. But in case of hydrogel, both hydrogel, almost the epithelium is fully grown. So that means the epithelium is almost done. And over a period of time, in other cases also, the epithelium is partially grown. But in case of hydrogel, this mostly it is grown properly. And in our case, so this is the standard image from a camera. You can see here. If you see this kind of structure within tissue, that is the scar tissue. If it is present in case of control, and in case of cornea also, if you see, the some amount of scar tissue is present, but over a period of 90 days, in case of bovine and human hydrogel, that is not present. So the scar tissue is not present. So this hydrogel is success. It can prevent the scar tissue formation. From this study, you can study. We have done also the OCT analysis, and from the OCT also we have seen that in case of typically we can understand the corneal thickness, the stromal thickness, also the epithelium thickness. All these things we have observed. Due to the limited time, I am not in the details of this thing, but the take-home message is this: in case of control, we can see the corneal is becoming thinner because we have removed the tissue and we have not put any hydrogel. But in case of all other things, the corneal thickness is maintained. Also, if you see here, this whitish tissue, that is the scar tissue, can be seen here in case of collagen and also in case of control. But in case of distressed tissue, that is the intensity is less than these 2 other things, collagen and control. So that's what we have observed from this study. And then also we have also done some pachymetry to understand the corneal thickness, and we found that in case of DCM and other things, the corneal thickness is almost like 400 to 450 micron, but in case of other tissue, it is becoming thinner. And in normal cornea, the thickness is in between 400 to 500 micron. And our histology data also support the same thing. In case of collagen, the tissue, the cornea, the tissue, the regeneration, that is, like if you can see here with normal cornea, it is very different. But in case of both this hydrogel, it is almost very similar to normal. But in case of control, the scar tissue is clearly visible. There is this whitish thing, the scar tissue is clearly visible. And pus staining also, it is for mucus, this thing, or sorry, it is for the peptide glycan. And that thing also clearly visible. In case of both this hydrogel, it is almost having similar features to the normal cornea. Then we have gone forward to bioprint the cornea, where we have used a molding concept because cornea is a convex shape. So if you want to print that convex shape, then we need a support structure to print that thing. So what we have done, this we have printed with a SLA printer. We have created a design of this convex shape where this kind of a mold, kind of a convex mold is prepared, and this mold is having the diameter of same like a human size cornea. And also now we are going forward with the patient specific mold. So where you can actually, from the patient OCT data, we can convert them into STL file, and we can get the design of this mold. So that will be a specific for a particular patient, and then we can use this mold. This is the 3D printed mold that is used for printing. Also for bioprinting, if you work on bioprinting, then you understand that the printing optimization of the process parameter is a big thing before going for actually 3D printing, so that our outcome can be very good. So what we have done, we have used our dissoluble cornea matrix hydrogel, and we have created different process parameters like that, because we are using pneumatic extrusion based bioprinter. So we don't at what pneumatic pressure the extrusion rate is better. So that's what we have seen. And in this case, if you see in 0.2 bar, that means the extrusion is perfect, so that we can get a nice strand. But in both the cases, like in this case, it is under extrusion, and in case of 0.2 is over extrusion. So we can actually basically understand that at 0.2 bar the extrusion is better. So we have used 0.2 bar. And if here you can also see we printed a different print speed, and what we found that in this zone in between, when the print speed is like from roughly from 6 to 8 millimeter per second, then we can print a better nice strand. So the strand is not, it's not more or less. In this case, if you see when the print speed is more, it is less. But when the print speed is low, it is the extrusion is higher. So that means the print speed, this length is not, or the strand width is not, is more. So we found a window in between 6 to 8 mm per second. Also printing speed here, another thing, the gap between the lines, or if you create this kind of lattice structure, the gap should be maintained so that we can get a porous structure. So that gap is also properly maintained when the print speed is 7 to 8. So we have used these two conditions, like our print speed is in between 7 to 8, and by this way we can get a nice printed structures. So that this parameter we have used for further printing this thing, and this is how our strategy for the bioprinting of the cornea. We have going from the outer to inner core in a circular fashion. We printed the structure. This is the before printing, and the under print, before printing, after printing. If you see, this is the bioprinted cornea here, before and after. This is printed. The diameter is almost close to 10 mm. And another important feature, what we observed when we use the convex mold, the thickness in the central cornea is less. In human cornea, how it is present. The thickness at the center it is less, and then the outer area. So we could get a nice thing, and it is handleable. So this is the some 3D printed cornea, and we can, that's what we can visible. We compared with the human cornea. Then the other thing also, we have done biological characterization. There is the non-bioprinted and bioprinted. What is the cell viability? We found there is not much difference between the viability of the. There is not much difference between the viability of the cornea. Also, cell viability is very much maintained here. And also the non-bioprinted cornea, also it is this swells less than the non-bioprinted cornea because of this alignment of the structural element of the collagen fibers and the cells that is present during the bioprinting. And also we have gone for the same thing, another thing also, okay, for these different markers. So for collagen type 1, keratinoid sulfate, and alpha SA marker of this cornea, and we found that it is in the bioprinted cornea, keratinoid sulfate is present, and it is in accordance with our earlier observation that the hydrogel actually promotes production of more cornea tissue specific proteins than the other one. and with the histological slides. But one important another important observation is that this bioprinted cornea, the mechanical property is not like the human cornea, because human cornea, if you see, it is much higher than the bioprinted cornea. So we are using some strategies to improve the mechanical properties of this cornea further, and this studies is undergoing. So our next step is to improve the mechanical property and also going for in vivo study of this bioprinted cornea. So in conclusion, we have developed a hydrogel or a material for as a biowick for corneal tissue, proper corneal tissue bioprinting. And this material is a easily available source, because in India there are many cornea biobanks are available. So if we can successfully coordinate with them, and we can get the non-transplant human cornea, and that is generally discarded. That is, there is no use of that thing. That is mostly used for research purpose. We can collect them and we can develop. We have developed a simple formulation process, and we have studied the biocompatibility extensively. So this material has a potential as a prophylactic material, so that it can prevent the corneal scar tissue formation. We have done many other characterizations. This I have not shown many of the data here, and also we have bioprinted a human-sized cornea and characterized it. And the future scope of this study is we are going forward with toxicology study for as per the FDA norms. Also, feasibility study on human corneal patient. That is our next step, and we have got a grant for that to study the preclinical and to do the preclinical and clinical study of this thing. And also, we are also interested in to study the DCM hydrogel for efficacy. We have done one round of study where we found some interesting results, that it can be used as a material for corneal stroma supplement, so that it can be used for efficacy of patient. These are references, and actually I'm happy to, or we are fortunate to receive funding from various funding agencies for this work. Our first work started with the DBT support, then we got ICMR, and recently we have got a grant from Padmavati Foundation for our clinical study. And this is the work mostly done by my student, Dr. Shibu Chamitra. He's a postdoc working in my lab. Thank you all for your time, and I'll be happy to answer if you have any questions and comments. And also, I'm thankful to Dr. Sibujan for providing me the platform to present our work here. Thank you very much.
Thank you, Dr. Falguni, for your presentation, and more importantly, for you to have joined and shared some great insightful, work that you have done in this particular area, especially cornea. In fact, we were also in touch with the ophthalmologist to then also join. But since most of our discussion was around hard and soft tissues, in the dental as well as the orthopedics, we probably could not connect through. But yeah, in the subsequent sessions, I'm also very sure that we will also have them engaged in sessions like this, because 3D visualization is an area that we are very seriously looking forward to. So in terms of a combination with 3D technology, because 3D technology has everything in terms of the offering. So thank you so much, Doctor, for your.
I would like to mention that so we are doing this study in collaboration with Every Prasad Eye Hospital. Dr. Sayan Basu is a cornea surgeon.
Okay.
We are doing this work.
No, very good. I mean, good work, sir, and good effort that you've been doing there. Now we will have. Thank you so much, Doctor, for your time.
Thank you very much.
Now we have two questions. Thank you so much. Now we have two questions to Dr. Vikramjit from Dr. Girish Rao, who is the Honorary Secretary from AOMSI, that is the Association of Oral Maxillofacial Surgeons of India. Doctor, would you want to come on the stage virtually, or we will just read out the question here? So, Doctor, any of you, Doctor, or either of you can share. I mean, get those. I mean, in the discuss panel, he's actually raised this pertinent question. It is.
This is Jayesh here. Can I take that first question here?
Please, sir. Please.
Yeah. So we have actually done the human clinical trial, Dr. Rao. So the pilot trial in humans has been done after all the in vitro and the preclinical animal trials. We have a GMP facility in our own lab which manufactures this. It has been approved by the drug controller CDSCO, and we have a test manufacturing license. We have conducted a first-in-human pivotal trial at AIMS Center for Dental Research and Engineering, and the study is completed. It shows excellent performance in human, and the trial closing report is being finalized and will be filed shortly if it has not already been done so by Dr. Roy Chaudhary there. So to answer your question, the human clinical trials have been done, and it shows excellent acceptance by the surgeon, ease of use, and so on, and the performance in terms of being significantly higher than the other the standard of care. Now the next step for us, as far as the bone void filler, is to do the pivotal trial, which is required by regulation. So first trial is over, the pilot, the pivotal is now being done. It has to be a multi-center, etc. trial. So we are well along, and it's because these materials are new. There is no predicate material here. Therefore, we have to go through this whole suite of testing, which we have done. So I think we are in good stead here, and soon we will be able to offer this. And if, in particular, if there are any surgeons like yourself who's interested in getting involved into the pivotal, will be happy to include you. Thank you.
Thank you, Dr. Jayesh. I think, as a clinician, first of all, I'm very, very keen that we have, made in India kind of materials. I mean, always we have used things like this, especially from, imported stuff, and it's very, very heartening to see that IT, Mumbai and IS, are doing such wonderful job. I mean, from the association, that's the Maxillofacial Surgery Association, we are very, very keen that we partner with, premium institutes like yours and ISA, and let's see how we can do a huge clinical trial. I mean, we have the clinical numbers, I mean, there are so many practitioners across the country, so we can draft a multi-center clinical trial, and that we can do it very, very rapidly if we join hands. And I'm really, really looking forward, because this is our day-to-day problem. I mean, as a clinician, every day probably I'll be doing either a sinus lift, or it could be an alveolar graft, which we use either bone from the hip or from other parts of the mandible, either an autogenous graft material or any of the Zeno or synthetic graft materials. I mean, this is our bread and butter basically on work-wise. So we can get thousands of patients into a clinical trial, and we can get the proof of concept. And I'm very, very excited to hear the great work which both of you are presented today, and I think we will definitely collaborate. So probably I'll come to Mumbai just to meet you and then have a discussion with you.
Yeah.
How we can take.
Yeah, sure. I'll be very, very happy, sir. We'll be happy to collaborate with you and take your expertise to do it further. So I'm putting my email in the chat box, and I'll be happy to be in touch with you. Please be in touch. Of course, Shibu is always
Sure.
there, but please be in touch.
I mean, you
Thank you so
can
much, Dr. Rao.
tomorrow we have a session, the AMS session, so you can see what we are doing in the clinical space, and nice if you see from
Absolutely.
that and we start talking to each other. I think sky is the
Sure.
limit to what we can actually start doing together.
Lovely. Thank you so much, sir.
Pleasure. Bye.
Thank you, Doctor, for your inputs. I'm just trying to reach the panel session also, which is actually on, which is on the main, which is the main session on 3D technology. Now, may I now invite Dr. Vikas Garg. Dr. Vikas Garg is the founder for Pragyastha. Again, we are very encouraged to invite aspirants and also respondents who are startups in the country also developing these new solutions. Doctor, congratulations and welcome to the event. So Doctor will actually share his insights in terms of what this technology can do in terms of silicon prints using gels and various other materials that you're actually working on. And predominantly the area of expertise has been in creating these for breast cancer, especially for artificial, breast implants. Doctor, so yeah, you can start your presentation, doctor. Yeah, thank you.
Great. Thank you, Dr. Shivu. And I will probably use this, you can say, platform as for creating awareness about what silicon 3D printing is and how it works and all that. So I'll start with our company's name itself, which is Prayastha, and everybody understands, at least in Sanskrit, that means somebody who's doing the prayas, and that's what we are also doing. That we are strive to provide personalized healthcare using a new age technology, and new age technology is of course 3D printing here. And what we do is we are a deep science in healthcare company, coming out from three different aspects: biocompatible elastomers, additive manufacturing, and healthcare. So definitely our focus is going to be elastomers, not really thermoplastics, metals, or you can say hydrogels. Already, we got incorporated in 2017, so we are roughly 4.5 years old startup, having 2 patents, India and US both granted, and one Europe as published. And what we have done is we have developed world's first 3D printer for implant grade silicon, which is one of the most, or you can say, best biocompatible materials that we know today. It's not a regenerative material; it's just a biocompatible material having synthetic origin, and has its own nuances. That's why new technology was required, and we will see that in coming slides. And what is the benefit of doing that? I mean, of course, once you have this biocompatible material getting 3D printed directly without using any mold or something, again, the sky is the limit. So I will look at it this way: in the body, the bone and the dental or the teeth. I mean, these are the two hard tissues. Rest all are the soft tissues, and you require a lot of there are a lot of applications which includes breast, nose, chin, lip, and your trachea, esophagus, calf, pectoral. So many of such applications there. And finally, what we are aiming is, our mission is to become a world leader when it comes to point of care 3D printers in healthcare, and bring personalization to all these soft tissue implants that I just talked about. Founded by two people, myself, Vikas, and another co-founder is Shilpi, coming from a material science background, dropped out of PhD, then always worked in making implants, and some of the names that you are already aware, I'm sure everybody is aware of, making different kind of implants, or medical devices. Shilpi comes from more of a non-technical background, and takes care of rest everything which is not technical in Presta, and having you can say worked in large corporations, for example Edsel, a PSU, and then coming from Maastricht University, and so many things. We have also been awarded this year's National Technology Award by the Union Ministry, their Department of Science and Technology. So bit of recognition that our company has received for our unique technology there, and many other recognitions in terms of, you can say, TV channels, newspapers, and various other platforms. And of course, very you can say acknowledging a lot of grant support that we have received from government through different phases of you can say our product, which is a silicon 3D printer. So various grants. And now let's directly come to the problem. So everybody knows silicon is the best known implantable soft material as of today, which is available. But however, it is not yet 3D printable. So if you go out and want to buy a commercial grade silicon 3D printer, maximum you are going to get is a bioprinter, where it's going to be a syringe printer where you can fill whatever material and then print. So that is not something which is scalable, and that's not something which can work with silicon. And why do we actually need to print silicon? So let me put three classes of problem in front of you. First, where there is always a pressure to restore the body symmetry. Breast is one such organ, and in fact all the facial prostheses will also come into the same category, because most of the times what happens is one organ has to be replaced, and the other organ is completely intact, and that is why what you need to do is you can say change, or you can say replace only one side of it, and that should be symmetrical to the normal side. Otherwise there is no point, or there is again asymmetry that is being created, and hence the mass produced solutions do not work in this category. Second important aspect is that we look at a human anatomy there. So definitely everybody will have one trachea dividing into and going into two lungs and so many branching. But if you carefully look at that, they have a unique contour, dimension and structure, and those are very, very unique as per the individual. So you can see this is a trachea here, but this is the best in class product that is available today. So definitely we need to do better and make these kind of products which are which can fit to the individual. Third important category is the pediatric side of it. So kids, when they need such kind of solutions, they may be at any stage, or maybe at any age there, and that is why they can be of any size as well. And again, such solutions which are only coming in standard size do not help these small patients. So definitely our motto there has become that solutions should fit to the people rather than people fitting into the solution, and that is with what motivation Presta has been doing its work. And just to tell you a little bit more about implant grade silicon, because there are a lot of miscommunication as well as confusions about the silicon. So silicon today comes in three different categories. First is a USP, commonly known as USP class 6. Though all three are called medical grade, but all three are not implant grade. Prosthesis, USP class 6 is a prosthesis grade silicon. It is non-implantable in human body, but still biocompatible for any usage that keeps the material outside the body. The second category is a short-term implantable material, which is good for any implantation which is less than 28 days. And the final or the highest grade is the implant grade silicon, which is meant for long-term implantation, greater than 28 days. In fact, it can go as long as 10 to 15 years. So that is the absolutely highest grade silicon, and that is what we print as Prayasta. Though we can do other you can say materials as well, but definitely our capability you can say goes as high as for the long-term implantable materials. And why? So obvious question that everybody asks, and probably coming to your minds as well. Why can't the conventional 3D printers do silicon there? And there is a reason for that. There are sufficient reasons for that, and I'm going to walk you through one by one. 4 of those reasons one by one. And that is also what made us build a new 3D printer from scratch. So that way we don't call ourselves a material company, but an instrumentation company, or but a technology company which can develop instrumentation for any kind of you can say materials. So if you look at today's print materials that are 3D printable, you will see either of these three form factors. Either you will see some filaments, you can say going into thermoplastic filaments, going into FDM printers, and then finally getting printed. You may see some powders, both metals and even many thermoplastics are also powdered, where using some laser technique or some you can say binding method, you can make a product or you can make an object. Then the third thing is more like resins or any liquids, where they have a photoactive component which cures them from liquid to solid as soon as that that material is shined with the right wavelength and intensity. However, silicon is none of them. Silicon is a elastomer, basically a very viscous liquid. Viscosity may change depending upon the grade of the silicon or various other parameters of the silicon, but it is still a liquid. So the conventional printers cannot actually use these form factors. And that is one of the first reason why conventional printers cannot do silicon. Second thing is the silicon chemistry itself. So normally the phase transition that happens from liquid to solid, those phase transitions are either driven by temperature or by light. or by any photo method. But silicon, again, presents none of them, or responds to none of them. Actual mechanism of curing the silicon from, or converting the silicon from liquid to solid, is actually a cross-linking reaction where a base polymer and a cross-linker has to be mixed together to actually make the whole, you can say, to solidify it. Again, none of the printers are actually equipped to mix two materials in real time, and they cannot really you can say make these or 3D print silicon at a scale because of that reason. Third is the photoactive part. We have slightly covered it into the first reason itself. So there are possibilities to create silicons that are photoactive, but yes, that becomes a material research. Here the advantage is that we are directly printing the implant grade silicon, which comes with the reputation of several decades as a biocompatible material, which was never originally designed as a photoactive material, and even today it is not a photoactive material. So all the photo based methods directly comes out of that question when it comes to printing implant grade silicon. And the fourth, which I was mentioning earlier, that it is possible to have a bioprinter with some 50-60 ml of syringe, or some small capacity syringe where you can pre-mix the silicon and put it into that and print it. Yes, for an R&D purpose it's absolutely fine, but when we look at a scale, when we want to make, you can say, a breast implant on an average which uses 250 to 300 you can say ml of material, and next you have to make multiple such implants. So the manual changing of syringe and loading of syringe is not really a scalable method, and that is why the conventional printers cannot do an implant grade silicon. And at Presta we have developed a unique printer for doing that. I'm going to show you that printer in a little while, but let's look at some of the application specific problems as well. So if you start looking at the breast, which is the largest soft tissue implant that is needed today because of breast cancer, so two solutions exist, as Dr. Shibu was also mentioning earlier. Prosthesis is one and implant is another. Prosthesis being an external solution, women can wear that inside a brassiere every day and then can remove it in the evening. Breast implant is a surgical procedure, fitted permanently inside the body. And of course, we spoke about the shape and size that has to be personalized. So in case of prosthesis, it's just about asymmetrical appearance, but I will say which a manufacturer might say that it is okay to have this small difference, but I will say ask the women whether they are okay with those small differences in their appearance or asymmetry in their appearance, and you will get your answer. For implant side, definitely it becomes a little worse because since implants cannot be modified in an operation theater as per the patients, what ends up happening is an unwanted or completely avoidable surgery on the normal side of the breast, which was done to match the implant side. It could have been completely avoided having there was a personalized implant available, but that was not the case, at least in today with the conventional products. And another important factor that I'm going to bring is the weight part of it. So breast is a large organ. It has a sufficient, or it has a considerable weight in the human body. And when we are talking about standard shape and size, automatically we are also talking about standard weight. Which again, these implants, since they are standard weight as well, they fail to balance the body weight, and because of this imbalance in the body weight, there are, you can say, long-term effects in terms of backache or change in gait, and so many different long-term issues that happens both actually with both prostheses as well as implants. And on the implant, some specific issues. So of course, if you have seen a breast implant, it's literally a structure of a balloon where there is a thick silicon balloon filled with a silicon gel inside. And very obvious first risk that comes to the mind is the leakage of that. So breast implant do leak inside the body. In fact, 9% of all the breast implants, in spite of all the great quality control, do leak inside the body. And once they do that, there is no, you can say, there is no escape. You have to immediately attend to it and remove the breast implant from the body. Otherwise, it can even be fatal if the silicone gel mixes with the bloodstream. So definitely, leakage of breast breast implant is a big problem, or the challenge with the conventional products. And the second thing is the flipping or the malpositioning of these implants. So what happens, again, because of the structure itself, breast implants, they cannot be anchored with the body, or they cannot be sutured with the body, not neither temporarily nor permanently, and that is why they're simply kept inside the body by making a pocket. And then what happens is, depending upon the physical activity of the women, they can actually get displaced from their position, or rotate in their position, or even at times flip in their position. And that is why almost 32% of the breast implants surgeries require a corrective surgery, because the implant has got displaced from its position. So these are some of the issues with the breast implant, and people have tried to, you can say, personalize them, but could not, again, because of the age-old manufacturing process of molding. So there can be an external mold, which is a conventional mold casting method, or there can be an internal template also, which is called mandrel, with so many manual steps there. So Prayasta, I will divide industry-wise. I will divide these problems into three important aspects, where the shape and size cannot be changed at a later stage, because the molds and mandrels are already designed and in the very early stage of the product development. And second is, wherever there is a mold, there is always a pressure to achieve the unit economics. So everybody wants to make many copies of the same product using the same mold, so that the unit economics can be achieved. And again, the manual steps, for example, you are seeing 6 steps here, and all of them are manual. These six steps are manually done, and there is a large cost that comes to train these people, in a large setup. And that is why, again, a unit economics pressure is there, because more the number of units that will be made is less is the number of, or you can say less is the cost to each unit. So that is why what we have made is world's first 3D printer for implant grade silicon. As you can see, it's a large machine, a completely production scale machine, roughly 800 kg in its weight and 4 feet on either side. I'm going to show you a video also, once we cover this slide. So it's a completely scalable machine. We deal with almost 14,000 ml of material in one go, and in a single refill. And our printers can work for weeks without any manual intervention or anything like that. And then a completely clean room ready machine, having inbuilt UV sterilization, suitable to work in a clean room, and a 3x faster printing also, which is coming from our unique curing mechanisms using IR lasers, heaters, and all that. So we can cure silicon as soon as it is dispensed. And of course, when it comes to the precision or automation or any versatility of the material, we are no less than anybody. So though the machine was originally designed for implant grade silicon, but it can do any other elastomer as well, and including the hydrogels when you are really ready to do it on a scale. So a completely digital manufacturing method, no need of any physical mold or mandrel, fully automated process, and enables a full decentralization of what we do. So just a small video of what this printer is. So this is the machine. It might look smaller, but it's a large machine, as I showed you earlier. A front door as well as HMI display and everything, and a back door also. So the machine is designed so that actually you can run a conveyor belt also through it if needed to get the scale. And then now the real machine. So this is the beast that 3D print silicon. This is the printing chamber. And all the software, everything is being developed in-house. It's a completely made in India product. And this is where the actual printing happens. So we mix the silicons in real time, we cure the silicon in real time, and finally prints it to whatever shape and size we like. And again, no limitation in terms of what is the shape. You can create a hemisphere, a tube, or any other random shape as well. Going forward, so the manufacturing is one aspect. So or it can help removing the molds. So the shape and size are personalized. But what about the other parameters? So we were also talking about the leakage and all that. So to solve those issues, what we have also innovated is on the design level of that. So our implants are not completely solid implants. these implants have a unique structure or a combination of voids and walls, which we have started calling novel internal architecture. And because of these combination of voids and walls, we can actually create, you can say, personalized weight as well as stiffness and touch and feel. So the weight of our implants is also personalized. Again, there is no liquid inside, so you can suture them with the body as you like. And again, the designs are not just limited to that. So there are multiple designs that are possible, and in fact, that is why we call it an architecture. It's not just one design. In fact, it's a plethora of design, and that is also as intellectual property lies. So our US patent, in fact, came without any defense. We didn't need the back and forth, reply and all that. It was granted in the first examination itself. Given the novelty of the design and the technology. To summarize the product part of it, 5 important value propositions. 3 of them, ascribe to, you can say, personalization, personalized shape and size, personalized touch and feel, personalized weight, and then the safety aspect of also, the fully rupture safe implant and a fully suturable implant. And again, these value propositions are not only limited to breast prosthesis and implant. We can do any soft tissue implant for that way. So be it tractal stent, nasal implant, chin implant, calf, pectoral, any of those, all of those are possible using the same machine. And that is why it's a single machine but multiple application. And many of you will maybe already aware that these implants are medical devices and comes in different classes. So actually do all class of you can say using the same machine. Definitely, we require patient data. So we for any kind of personalization, so we do use mammography data, shape and size data, which is done by using a 3D scanning. Use density, create the unique novel internal architecture parameters, optimize those for the patient, and then finally create a personalized product. So this is the process flow that happens. And we have tested these products with some users as well. Of course, depending upon the classes, the different products are in different stages of development. So our implants, we have checked with the initial, you can say, in vitro testing, as well as some mechanical and chemical property testing and the relevant standards, and all have been found in the right you can say compliance. And some interviews or some acknowledgements from the doctors or the users regarding the need of personalization in breast implants or even in breast prosthesis. So that is also there. This is also where we are. This is a breast prosthesis trial that we are already running, where a conventional prosthesis completely fails to you can say restore the body symmetry. A personalized implant does a much better job for doing that. And this is where I will end. So the future of healthcare is actually the mass customization, and we really have to get out of the mindset where a single product is being developed, or maybe tens of products are being developed and people are getting fitted into that product. So we have to make products that fit to the people rather than otherwise. That's all. Thank you very much, and I'm open to any questions that anybody might have.
Yeah, thank you so much, Dr. Vikas, also for the efforts that you have been able to make in terms of this area of your expertise. Now, Doctor, I have one question. Now, we have actually now going. I mean, this is commercially 3D printed machines that you already have up and running, right? I believe.
No, so these are machines that are developed in-house. These are not available commercially. So as of today, as Dr. Shibu, you probably are aware more than me. You can buy a metal 3D printer, you can buy a thermoplastic 3D printer, many of that, but you cannot buy a silicon 3D printer, that to implant grade. So these are not commercially available machine. This is a fully in-house developed machine as well as technology.
Okay. So right now it's to do with these clinical trials to an extent that we are actually involved in, right, doctor? In terms of
Exactly. So processes.
specific patients.
Exactly. So Prosthetist, which is a class 1 device, we are already running some field trials, which doesn't require a clinical trial or so. For implants, definitely it requires a clinical trial. And what we are doing right now is an animal study where where we have been funded by again some grants, but the implants are in the animal trial stage.
Okay. So I have a question from Dr.
Yeah.
Jayesh Ballari, sir. He's already in our panel. He says, what is the
Mm-hmm.
smallest feature size of one can print? What is the smallest size in
Okay,
terms of
so sir,
attaining the
I
smallest
will, sure, Dr. Shibu. So, sir, I will divide your question into two actually. If you want to make a single object only, probably we can print as small as 5 mm and nothing smaller than that. But if you are looking at a feature in a printed object, we can go as small as 50 to 100 microns. So that is so the running accuracy or the running resolutions of any printers are usually smaller than the actual size they can or size of the object that can print. So I hope I answer your question there.
Yeah, can I just follow up on that? Yeah. So
Please,
suppose
sir.
I want to, let's say, print. Suppose I want to print an O-ring which is 5 millimeter in diameter, and the cross section of the O-ring, let us say, is 1 millimeter in diameter. Yeah. Would
Possible,
that
sir.
be
Possible.
possible?
Answer is yes. Possible, sir.
And the cross section of that O-ring would be perfectly circular,
Yes, sir. Yes.
1 mm diameter
Absolutely.
O-ring. Okay,
Absolutely,
great.
sir.
So I have such a need. Can I get a part made from you on payment basis?
No, so the way I look at it, sir, you may not need that part in an implant grade silicon. So this is a scalable machine. Usually, once we load,
No, let's
we load
say,
almost.
but let's say I need it. Yeah, so you are in a position to give it because I do want it for an implant, for which we'll take the responsibility.
No problem, sir. So I'll be happy to talk
Okay,
offline regarding that and happy to support you in whatever way we can.
okay, great. So Shibu, put
Yes.
us in touch. Yeah.
Yeah. Surely, sir.
Yes.
Surely, definitely.
Thank
So,
you.
thank you so much, Dr. Vikas, for your insights and on the subject. And I'm sure that's exactly what our consortium is also all about in terms of seeing, that the right connect is met with, and the solution is then probably
Absolutely.
offered to the requirement. Thank you for your participation. And now I will go to
Thank you.
the next speaker. Uh, Now I have Mr. Piyush, who is also and indigenously manufacturing 3D printer, bioprinter in the way and the scale. And I believe that we all started the same time, Piyush, almost 5 to 6 years back in terms of when
Yeah,
it was
pretty much.
more or less a center. Yeah, so I mean, we have almost 8 years in terms of where it all starts, I believe. Yeah. So the founder is Alok, who is also actively been traveling globally, trying to promote their products and solutions. And here is Piyush Padmanabhan, who is the co-founder and the CEO of Next Big Lab, who is also an indigenous, manufacturer of 3D bioprinters, and also have been doing some great work in the space. So we will have man himself share the insights in terms of what has been achieved. Thank you so much, Piyush. Please,
Thank you,
over to you.
Shibu.
Yeah,
Thank you.
hi Piyush, this is Jayesh. Welcome, and
Hi, Jay, sir. Hi.
yeah, so nice to see you again. But
Yeah,
unfortunately, I have to drop out, so that's why I'm interrupting you.
sure, sir.
Shibu, I'll try to come back in a little later, but I need to go to another meeting, so I'll be in transit. Thank you all. Bye now.
Thank you, doctor.
Thank
Thank
you.
you.
Bye. Thank you, Shibu, for the opportunity to speak. And I think, yeah, we pretty much started at the same time, right? I think I'll just start presenting my screen. Shibu, is it visible?
Yeah, it is.
Okay, great. Hi everyone. I'm sure at some point of time I've met everyone on the panel, or I've spoken to everyone at the panel. But hello to everyone else who's also attending the session. Today, my focus is going to be on just introducing to you about what we do as a company at Next Big Innovation Labs, and also a couple of interesting projects that we are working on. Without any further ado, I'm Piyush. I'm one of the founders and the CEO of Next Big Innovation Labs. We've been working in the field of bioprinting for the past 6 years now, and we consider ourselves to be a deep tech bioprinting company that's focused on developing products and solutions around the aspect of 3D bioprinting. Now, obviously, we started off in May 2016 But obviously, even before that, we were having a lot of discussions with experts at that point of time in the field. And we started up initially by building out the technology, basically building out the bioprinters themselves. And we when we started out, we had to buy it from outside India, and obviously we didn't have that much money in our pockets at that point in time. And luckily, we got some support from the central and state governments to build out a bioprinter from India as such. So that's how Thrivima came to be. We utilize patented versions of our technology to bioprint human skin. The project is currently underway at our labs at BBC, Bangalore Bioinnovation Center. And we also want to make India the hub of 3D bioprinting globally. That's one of our goals as a company. And in the pursuit of that, we want to actually build the awareness about the technology, what is possible, what is not possible. Because a lot of people, when they think 3D bioprinting, they think that, okay, we can look at bioprinted liver, bioprinted heart, that can directly go into transplants. That's how we also started. But then I think the truth is far away from what it actually is. There still has to be a lot of work that has to be done on the technology. There still has to be a lot of work that has to be done on the biomaterials, as well as even when it comes down to regulations, government regulations. So there's a lot of things that have to come into play: policy, biomaterials, and technology. So how we are coming on board is on the technology. We want to see how we can push the technology forward and make it as customizable as the biomaterial or the cell type people are going to use. I'm sure a lot of you have heard about 3D bioprinting or have seen the process of 3D bioprinting. But basically, it is this: you have the cells that are loaded into the biomaterial or the bioink that's printed on a layer-on-layer format to form the scaffold. Now, this scaffold is then given 1 to 2 weeks sort of an incubation, or even 3 to 4 week incubation period to finally form the tissue product. But yes, this is the basic crux of the technology as such. Uh, Obviously, we all know about the applications of bioprinters as well. Right from tissue engineering, where you're developing, like for example, us, we were developing skin. You have other applications where you're looking at people who are developing bone and all the other organs. But then there are other implications of the technology as well, and that's what we learned over the past 6 years. It doesn't only have to be tissue engineering; it can even be cancer research, where we can specifically include microfluidics in order to understand better how cancer cells behave in their microenvironment as well. Yes, recreating the microenvironment is very difficult because it differs from patient to patient. But if we can get closer to that, that should be the pursuit of research, I feel. And the other one is obviously drug discovery, personalized medicine, and all of that. But then now recently, with LF farms coming and bioprinting meat that can be used for space, and with a lot of people across the globe working with nanobiowings as well as novel biowings using novel hydrogels. We believe the application is going to be far and wide. The most recent application, someone had spoken to us, was about printing electronics, where basically they wanted to use the same bioprinting technology to print electronics as such. So we're working with them closely to see how we can build a customized bioprinting solution for them. Um, this is our bioprinter Thrivima. So Thrivima in Sanskrit means three-dimensional. Here's a short video of basically, the machine doing a dual extruder print. And here basically, this was for Central Leather Research Institute in Chennai, where they were basically using it for applications for alt leather, which is a very, very unique application. And yeah, they wanted to work with certain light-based polymers and things like that. And we were able to actually, develop the technology for them, customize it for them. And that I feel, in Vikas had mentioned in his previous talk, where, you're looking at customization, and customization is going to be key. And we want to bring that on board on the technology front. We want to see how we can customize the solutions from the technology for true clinical applications. And, we obviously customize on a higher level. We customize the number of extruders. We customize. You can go up to 4 extruders. We can customize the amount of temperature control, cross-linking, your sterility options. All of this can be customized. But then, we obviously this is offered by almost everybody in the field. But what we do is we go into a more micro level and work with researchers in India and outside India to develop different technologies that they themselves can use. So, we basically look at different kinds of technologies, right from inkjet extrusion. Although inkjet extrusion is being used in bioprinting, there's a lot of applications in printed electronics. Another very, very good example is triaxial printing, where you can find an application in bioprinting, but then again, you have it in electronics as well. There is a certain set of people are looking at that as well. We customize the build volume because we understand that when you're looking at a machine, when you're looking at a bioprinter as such, we want to customize the build volume based on what the researcher is working on, be it bone or be it a very small, 0.5 centimeter square area size of human skin. And obviously, we are also looking at multi-well printing and all these other things, as well as customizing the software based on the researcher's requirements. And we understand that this level of customization is going to be extremely crucial in order for people to actually translate their research. Now, all of this is also there, but then the next level that we go to is actually work with them and try and see how we can also future-proof this machine for future upgrades as well. So it just doesn't stop there. So I'm just going to talk about how this entire thing started with us in terms of customization, and a very good case study on how it has helped us get to this stage. In 2018, we got selected into the Merck Accelerator program. This was in Darmstadt in Germany. And as a part of the accelerator program, we were one of the two teams globally, they get close to around 400, 500 applications, and only two teams are selected from India. We were one of them, and the other one was a microfluidics company. So we worked, as a part of the program, we got to interact with a lot of people within Merck, explain about bioprinting technology, speak to the internal teams at Merck to understand how the technology can be utilized within their labs for a plethora of applications. And obviously, we had a lot of interactions with scientists who are working on crucial projects within Merck, such as novel drug discovery as well as vaccine development. And that's when we thought of looking at how we could go further and work with one of the teams very closely. One of the teams there working on bioprinting had given us a very interesting project. They wanted to print in a 96 well plate. So for all of you who don't know, this is a 96 well plate. They wanted to print within this well plate, and they wanted the dots to be exactly in the middle, and they wanted just one droplet to be printed. So yes, this was pretty straightforward. And generally, with other bioprinters, it was taking close to around 16 minutes. We introduced a new technology at that point in time in 2018 called tandem printing. It was at least new to us. And using that, we sort of brought down the printing time to, close to around 4 minutes. Now, with this, obviously, the control that we were getting in each system was improved, and obviously, we thought the project was good. They were happy. Now, the next phase, we didn't know, they threw a curveball at us, where they said, okay, you print one drop, and I want you to print another drop exactly on top of that drop. Now, it's easy to call, one extruder head to a point and print, but then getting another extruder head to the exact same point and printing a drop right on top of the other required a lot of changes that we had to do in order to ensure that the backlash that we were getting, generally when you're working with engineering systems, you're working with a certain error rate. And we had to bring down that error rate to a very, very big extent. And that's where, we actually we developed our first patent, which was the anti-backlash system that actually allowed us to print one drop. So you see a blue drop over here, and exactly on top of that, there was another droplet that we had to print, which was a different biomaterial altogether. This was obviously a test gelatin ink that they wanted to test with. But yeah, this is just for to show you all what exactly we were able to achieve with the technology. Obviously, all of this was customized to Merck. Even the software that made this happen was customized for Merck. Now that they saw this, they said, okay, we are doing another form of co-culture studies where we wanted to print one line beside another line. Now imagine printing this in a very, very tiny well. You would appreciate from this picture that the well is extremely small. It's close to around zero point 0.5 centimeters, if I'm not wrong, or even lower. And we had to draw a line within the well, and that's something that we were able to do as well after discovering the anti-backlash system here. This project obviously was utilized by Merck for co-culture studies, where they were doing specific studies for tumor models, as well as to understand how they can recreate certain microenvironments and all of that. Very interesting project, but this showed us the true potential of how technology customized can actually help in developing some novel solutions for clinical applications, or even for drug development in this case. So, we also worked with other scientists in India. We when the technology was developed, we sort of told people that we had a bioprinter in house. We wanted to technically validate it, and many researchers were nice enough to give us. The first one was at Majumdar Shaw Center for Translational Research. So they had given us polycaprolactone and gelatin, which was the first biomaterial that we printed with, where we had printed these complex hexagonal structures that they wanted for, again, studying breast cancer modeling. The next one was a pure synthetic polymer, which was PLCL, polylactic caprolactone, which was used for intraoral wound healing applications. And here again, they had just given us these granules of PLCL, and they had asked us to basically print with it. So we had to develop the solution as well as print with it. The next one was bioceramic biomaterials, where we had to actually fine tune the machine to work with bioceramic slurry. So the researcher in this case had already optimized his ink, and we had to optimize it further for bioprinting, where we developed Trivima's unique temperature control system, which we again have a patent on for the extruders. So this is where we developed the bioceramic printing aspect of it. And then obviously we had different polymers that we were utilizing for skin and testing for skin, that we had printed using this. Uh, Over the period of time, we were able to also print with light-based polymers, where you have UV-based, as well as here in the Merck project, it was visible light-based printing. So we pretty much had to print in a dark room. And it was very difficult, but yes, we somehow managed the droplet based printing there. And then obviously when you're looking at optimizing the bioprints, that's another key factor here. So we help our research partners, as well as our clients who use the printer, to optimize their designs, and to understand how they can really get the complete advantage of the bioprinter. So we have a saying within NBL where we allow the researcher to hack the printer. Most printers come with a locked system. You're not able to do much, so we allow people to actually hack the entire printer and play around as much as possible, and make it as customizable, modular, and easy to use for customers. Um, so yeah, apart from that, Trivima, we offer a lot of services around Trivima, but the main thing being that it's customized and it's future proofed. Um, we've had a lot of good technology partners along the way. Autodesk is one of our earliest partners. They provided us with all the softwares that we needed to develop the boards, as well as to develop the technology around it. But the most recent partner in August 2021 we is Microsoft. So Microsoft, we're utilizing their platform basically to develop an AI-based bioprinting platform. Now, the focus of this AI-based bioprinting platform is for the machine to think by itself, to understand, okay, am I going right or am I going wrong? Is the scaffold being over extruded, under extruded? Are we having scenarios where you probably have to change the needle gauge and all of that? So we've started working with Microsoft. We're going to publish our data soon, but this is the initial set of data that we have right now, where we've taken close to around 8,000 samples of different spiral scaffolds. and basically we've augmented them to understand how different scaffolds can be classified. Now we have a good spiral. You can see you see an under extruded spiral here. You see an over extruded one. We have classified them into different various aspects so that you can actually understand at what level your scaffold is printing. Is it a good, bad, or even when good and bad, good under extruded and over extruded, you have different subsets. The same thing again, just another data set. And here, this is more of a lattice scaffold where we had given different data sets to the system in order to understand it, in order for it to understand what is being printed and how to analyze this. So we have got close to around 100% hit rate on the good scaffolds, as well as when you're looking at the under extruded scaffolds, we are also getting a good hit rate, as well as the over extruded scaffolds. So with this, now the next step is to understand, this is with one gauge, right? What I'm showing you here is with one gauge. What we're planning to do is take close to around 10 to 12 gauges and look at how we can have a plethora of data sets that the system can understand. Just by putting in the gauge, putting in the biomaterial, you'll be able to understand exactly what is the pattern that you're getting and if the pattern is good or bad. That's what we're working with Microsoft, and it's a very interesting project. We've progressed over the years since 2016, supported by grants, Merck, and we've had a lot of partnerships along the way as well. And obviously, we work on three levels. We work on Trivima, we work on Lexmic Learning and InnoSkin, but obviously we have collaborations across industries, and we look to see how we can collaborate with researchers from academia as well as industry to develop novel solutions that can be applied in bioprinting as well as for a clinical prospect. We've been supported by the Bangalore Bioinnovation Center as well as Jyoti Institute of Technology through the Atal Incubation Center, and obviously BIRAC, Government of Karnataka, and Department of Science and Technology have helped us with the funding for most of the work that we do. With that, I'll end my presentation, and I'll keep it open for questions in case anybody has anything. I'd be more than happy to answer them.
There are some questions which are.
Yeah.
So I have also Dr. Vikas, who has just joined, and he's an orthopedic surgeon, and he's also the past president for Gujarat Orthopaedic Association. So he had one question that he was.
Yeah, sure.
Shibu, am I audible?
Yeah, you're audible,
Yes.
doctor.
Yes.
You can
Yeah.
ask your question.
So, really a nice presentation from the biological 3D technology point of view. I was just asking, being an orthopedic surgeon, whether is there any research which is going on as far as you can print ligaments, especially predominantly the collagen tissues, or you can think in terms of printing the meniscus.
Yeah, someone had approached us with a project similar to this, and yes, I think, they didn't receive the funding for it, but yes, how we work is we look at it from a grassroots level and start approaching the problem from there. So obviously, first we sit with the clinicians, understand exactly what the underlying problem is that you're trying to solve. Then from there, we start working our way up to see how we can develop different products or develop different solutions around it. So with respect to that, yes, we generally consult and we come on board and help see how we can help you throughout the process. So if that's something that you're interested in, we can discuss it and try and look at it. But yes, I think there are solutions that people are working on, if I'm not wrong. And from what I understand, there's a lot of work happening outside India as well, specifically when you're looking at osteomalacia and all these cases. So there are a lot of research that's happening. But I'll open it up to the panelists, in case they might also
Yeah,
have some good inputs as well.
sure. But it would be really interesting because
Yeah.
presently, mainly into orthopedics, from the 3D technology point of view, we are mainly working on implants, the metallic implants. And the soft tissue 3D printing is something which would be far more of an interest to a lot of orthopedic surgeons across the globe.
Yes. Yeah. Very true.
So if
And
there are any researchers in this group, who are thinking in terms of doing, even if you think in terms of bone is the hardest tissue which is available in the body, right?
yeah,
So in case you can also think in terms of doing a bone printing, where we have trauma patients with bone defects. We have a lot of patients who are onco-orthopedic patients, who have, where we removed large part of the bony segment, which is tumorous. So that is where, probably there could be solutions. It's all at the speculative level, presently. But then being all innovators and researchers which are there on the panel, and all of them are working in the different fields, I thought I should ask this and I should take this opportunity. Thank you, Shibu, for giving that opportunity to me. But it
Thank
would
you.
be really nice to hear from someone else who is also working in a similar area.
Right, right. So Piyush, you should also join tomorrow's session. We have a session
yeah.
dedicated for orthopedics. So
Okay.
there are two tracks, track 6 and track 7. Track 6 actually talks about all the technologies, and then we will also have a panel discussion. Maybe if you are around, maybe you can also join. Maybe, Doctor, we can also address the soft tissue part, and also, I can also invite the other gentlemen also to join in.
Yeah, yeah. So if there
Yeah,
are people, because the orthopedic surgeons would not know about it, right? So
exactly,
we are the
exactly.
people who are more focused in the theater, and somehow large part of the technology we are unaware.
Right, right.
Dr. Shibu, if I can comment on Dr. Vikas's
Sure.
question,
Yeah,
will
yeah.
that?
Please, please, please. Welcome, sir.
Yes.
Please.
So, Dr. Vikas, just wanted to inform you in the way that silicon can also be a good candidate when it comes to creating the volumes. So we see a lot of cases, not directly. We have not really went to the clinic to actually solve it, but we are aware that these cases where bone, you can say, replacements are done either by a standard or a personalized implant, but the volume also has to be, the volume, the shape also has to be stored and restored, and that is where the silicon volume or silicon implants come into the picture. They
Okay.
are more of a structural in nature rather than any functional, so they may not make the muscle, but whenever the symmetry has to be restored, the appearance has to be restored, of course, the silicon implant is one of the solution that can work, and we are happy to I'm happy to talk further on the topic.
Sure. So that is interesting. Silicon implants, what I understand, would be, as you rightly said, would not help us to give the rigidity that is required actually. So that is exactly the reason why we were requiring a more biologically printed material, which could be a good substitute for the ligament, which is predominantly collagen type 1, type 2, or maybe for this. So silicon could be a good spacer. That is what I believe, Dr. Vikas, right?
Absolutely, you are right, a very good spacer and
Yeah.
very good, you can say, filler, wherever
Filler,
you just
exactly,
need to
exactly. So
fill the volume.
most of the breast augmentation procedures that are done by cosmetic surgeons, I think they use silicon as a material.
Exactly.
Uh, However, but the only thing is the body has to accept silicon in a being an implant. Anything which is explant, which is used outside, silicon is okay. Being an implant, sometimes you have little wary about the body's acceptance to that material.
Definitely, sir. So as you rightly said, and I think you already are more aware than me there. So there are these implant grade silicons, primarily used for breast implants, and as far as I know, the only or one of the few complications were related to the surface of the implant,
Surface, yes.
which eventually become capsular contracture and ALCL and things like that.
And the
However,
irritation, it's a soft tissue irritant sometimes.
exactly.
Sometimes. Very few.
So that way, the 3D printed implants, we have a unique surface that has not been, I will say, put into a clinical use yet. And that is also where we are doing some studies and I'll be happy to get back to you with some results,
Sure, sure, sure.
positive
And
or negative.
Shibu is a common connector. Shibu can always connect all of us together.
Definitely.
Yeah.
Thank
Dr.
you.
Dr.
Shibu, one
Vikas,
more question I wanted to ask, if anyone is working on epidermis. Epidermis is basically the skin. So lots of patients who have burns or contractures, and that is where you can do a lot of reconstruction using 3D printed skin.
yes,
So
yes,
anyone
yes.
has any experience, because I see a lot of innovators and researchers on this panel.
Right,
So
right.
we at Nextpeak Innovation Labs work on 3D bioprinted skin. So we are currently developing the epidermis, and
Wow.
the application is as an alternative to animal testing initially. But the goal is to see how we can develop a full thickness model, which will have both the dermoepidermal layers that can be used for treating certain types of wounds. So this is specifically what we were looking at. But I think, Doctor, because we can actually, discuss offline. I can get my
Sure,
biotech team as well, and
sure.
if there's any project that you have in mind, we'll be more than happy to come on board. Because clinical is obviously the way to go, and the next focus for us is that, and we'd like to start it sooner than later.
Done, Piyush. Thank you
No,
so much.
I think, Doctor, the only reason for us to have built this particular forum is also to see that these gaps needs to be quickly dealt with. As Dr. Girish Rao also sir mentioned in the morning, we need to work in confluence together to see that how we can eventually look at clinical trials, activating it in terms of taking it to the next level. So Dr. Girish Rao is also the honorary secretary with AOMSI. Dr. Vikas, you were not, you were actually invited in the morning. We missed you in the morning, but we had a good discussion. Doctor, please, you had something to.
Yeah, I just wanted to comment for both Dr. Vikas and Dr. Padmanabhan's lecture. Brilliant, I mean, especially the biggest challenge which we are having is the soft tissue reconstruction, and especially the implantable soft tissue. I mean, whether it's silicone or whatever newer materials which we're using. I mean, when we
Yeah.
are dealing with things like hemifacial microsomia or facial asymmetry, many a times these kind of situations are extremely challenging for us as clinicians, and we have been struggling a lot. I mean, bone is much easier to handle. I mean, you can put metals in, you can put PEEK on top of that, but the soft tissue contour is probably the biggest challenge. And I still remember when we were having these silicone kind of materials, which we had to carve, and get the shape there is such a difficult thing. And 3D printing of these things can really, really be actually a game changer, is what I feel. But I think one concern what we have when we're dealing with orofacial region is infection, because a lot of these soft tissue materials get extruded over a period of time. So that's something which we need to look at too, how we can, put in materials which somehow basically deflect or prevent bacterial contamination or viral contamination on these processes, where we had to take out these kind of processes. So I think that is something which we need to work on too, especially if we are going through an oral approach. The possibility of
Yeah.
contamination is extremely high. When we're going from the skin, it's so much easier. But every time there is a breach from inside the mouth, we have lost the prosthesis, be it a metal, be it a soft tissue thing. So I think in these kind of forums, if we can bring in researchers who can also talk about materials which are repellent towards bacteria, or bring in nanotechnology or certain materials which can leach out long-term antibiotics, I think we are going to be winners in the long run.
Thank you so much, Doctor. Thanks for your input, and
Shibu,
thank
I
you.
think we had one guy who was talking in terms of antimicrobial coating, right?
Yes,
Correct.
yes.
And I think Dr.
Yeah,
Girish Rao has very rightly raised an issue,
right.
where the use of nanotechnology can be utilized, where if you can use most of these 3D printed materials, but you also think in terms of coating them with something which is antimicrobial.
Antimicrobial, yes,
It
yes.
will,
In fact,
yes.
Dr. Girish, we had discussed this. There was one session on orthopedics very recently, where Dr. Vikas Jain was also one of the key respondents. And it was all for the orthopedic surgeons when it comes to while surgery, cause of infection. So we can now have these antimicrobial materials which can be 3D printed, and you can also have these medical devices that can be used. So, sterilization can be also probably, infection is the major problem, so we discussed about antimicrobials. So this gentleman is going to join from Chile in one of the sessions in track 2 on orthotics and prosthetics though. But tomorrow he will also be joining in our session for orthopedics. If you only thing is his time, morning here would be like midnight there, so that's a challenge. Or else in our session in the AOMSI event in the morning, doctor, I could have invited him also. But let me see, I will check is a possibility how we can manage. But he's going to talk about antimicrobial materials. So he's also looking at the markets in India to see that how we can work with clinicians going forward. So good, sir.
Sure.
Thank you so much.
If you can connect, that'll be fantastic.
Definitely,
Thank you so much. No, really enjoyed the morning. I also have another meeting. I think I'll have to take leave. I'll see you tomorrow.
Thank you so much, sir. Thank you so
Pleasure.
much.
Such an honor to be here. Thank you.
Always a pleasure, sir, to have you on board, sir. Thank you so much. So, gentlemen, now we also have one session dedicated on the software part, because now we all talk about the tissue, but it is also important for us to understand, how the dissection can happen with the software and simulation. So here is a speaker from IMS who will also represent Simpleware Synopsis, which is a software company and also simulation. So Gaurav Kumar will actually share that aspect to cover his area of expertise on the subject on simulation softwares. Gaurav, you can start your presentation and then we can take it from here.
Thank you, Doctor. Thank you for the introduction. So, good afternoon, everyone. This is Gaurav from Integrated Microsystem. I work as an application engineer, and basically we are working on 3D image processing and simulation. So in this presentation, I am going to basically show you that how you can synthesize soft and hard tissues using our Simpleware software. So in the first part, we will have a very small presentation giving you an overview about the software, the capabilities of the software, and then I'll show you a live demonstration of the software with a very basic example to giving you the idea about the workflow. So let me just share my screen. Yes, so Simpleware is basically a software which allows you to process 3D images, and you can perform segmentation, also some scientific calculations as well. And later on, you can export your 3D image data to the universal 3D format, that is basically STL, for 3D printing or further analysis. And basically, Simpleware can be used for life sciences and clinical applications as well as materials and manufacturing. And you can see some of the work application areas, like the people who are working in the field of orthopedics, product design analysis, physical flows, medical devices, research and development, printing preparation, and the people who are working in the field of materials and manufacturing can also use this software for reverse engineering, additive manufacturing, non-destructive evaluation. All these applications can be conducted inside this software. So these are some of the other categories. For orthopedics, you can generate automated and semi-automated tools for segmentation. You have CAD implant design and anatomical data section, and you can also quantify bone geometries, etc. For product-based designs, you can virtually check the fit and fit efficiency if you want to calculate stress strain for different materials. So all these physics, like all the analysis related to the physics and chemistry of a specific materials, can also be conducted using this product design and analysis section. For cardiovascular and respiratory systems, if you want to cross-check the physiological flows, if you want to generate new flows, all these kind of things can also be done in this software. These are some of the more application areas: EMN, neuromodulation, medical device research and development, 3D printing preparation. You can produce high quality STL. inside Simpleware, there is a separate section for 3D printing that I'll show you in the live demonstration, which allows you to export any model in the STL format. So these are some of the modules in the Simpleware. It supports finance elements meshing. It has nerves, it has CAD. You will also have some physics modules, which allows you to perform, as I've told you, that some of the physical calculations can also be performed on these specific 3D models. So you have solid, flow, and Laplace for that. Also, there are some automated solution modules, which allows you to perform auto segmentation from specific body parts. Like it has an auto segmentation for orthopedics, it has an auto segmentation for cardio, and there is a custom modeler also. So Scan IP is basically the GUI of the software. It offers you all the tools related to the segmentation, printing, post-processing. All these tools are inside the Scan IP module, and you have the flexibility to import multiple images from different medical devices. Like if you have images from MRI or CT scan, DICOM or DICOM 4D DICOM, all these kind of images can be easily imported. And so these are the import formats supported by the Simpleware software. You can import the basic image formats as well as some specific software specific imports like raw image data, meta, DICOM, metal images, AVI, PDF. All these kind of modules are basically available in base module. So all the imports are possible. This is the FE module. It allows you to perform finite element meshing, and the module offers the broadest range of image-based meshing tools, and it allows you to generate robust meshing out of the DICOM images or the data set that you have. You can rely on this meshing because it uses an algorithm which is based on finite elements. So it provides you with a very great flexibility to directly generate the mesh directly out of the images. You don't need to code anything or fed in another algorithm. It is basically, it's based on AI, so you have to just simply import the image and it will generate the mesh for you. These are the export formats. Some people if you want to simulate your model further in some other software like SolidWorks or any other software, so you have these software specific exports for Abacus like ANSYS, COMSOL. So all these for MATLAB. So all these export formats for specifically for meshes are also there in the Scan IP module. This is the NURBS module. So basically it's a non-uniform rational B-slimes. It basically allows you to generate models to CAD packages. You can directly export the NURBS like 3D images from NURBS module to the some other CAD simulation software, and it basically allows you to easily convert 3D image data into CAD models. And it's very quick, it saves times and benefit from high quality model generation. This is the CAD module. So it offers all the CAD imports and exports. The module combines the realistic details of 3D image with the idealized design features like the desired design or specific model that you want. So Simpleware CAD also provides an internal structure wizard for integrating lattice structures into CAD. You can synthesize super lattices using this CAD module. It has also this design link which allows you to connect this software directly with the SolidWorks. You can use both the software simultaneously to generate 3D models. You can create implants or design implants in SolidWorks, and then you can import them directly into the Simpleware using this design link, and then you can perform segmentation. For the segmentation, as I've told you, there is auto segmentation section also, which allows you to segment some specific body parts for cardiovascular or orthopedic applications. Like it's very easy. It's completely based on AI. You have to simply just choose a model and it will automatically segment the whole data set for you. So this is the physics module. It has solid, Laplace and flow. This is useful for the people who are working in the field of materials. They have some set of theories of their own. These all modules have they allow you to calculate all the absolute values according to type of the your application. Yes, so these are the automated solutions. So Simpleware has automated solutions that are powered by AI technology. It utilizes the machine learning algorithm, and you have to simply just import the data set, and it will automatically identify or analyze those images and will generate the 3D model for you with the help of the machine learning algorithms. You don't need to do any kind of manual segmentation for every part individually. So this is for the AS ortho, like hip segmentation from CT scans are included, knee segmentation, femur, all these kind of bones. The auto segmentation is supported. Also, why do use automated solution modules? Like, it is very fast. You can see if you are going to manually select or segment the whole image, then image data set. So for example, for this specific example, it will take you around 38 minutes, but with the help of automated segmentation, it will hardly take you about like 2 to 3 minutes. And this auto segmentation has very less chances of errors. It is much faster as compared to this manual segmentation. And also for manual segmentation, you need to have a very good knowledge about the whole medical anatomy, as well as the how 3D images or segmentation works. But for the auto segmentation, like this part is basically eliminated. Anybody can do the segmentation part using that. This is for the cardio heart segmentation from CT scans, left and right, arteries and ventricles. All these segmentation can be done using this AS cardio module. This is a custom modeler. Basically, this software is based on Python language. So if you want to make your own auto segmentation for specific body parts, so you have that flexibility of using that Python developing console. There is a Python console inside the software which allows you to make your own plugins or own automated tools. So that is why it is called custom modeler. These are the basic system requirements. Like in order to run the software, the system requirements are very basic, but it depends upon your data set. Like if you are working on a big data set, then you definitely need to have a very good capable hardware for that. But for basically, you can, if you just want to explore the software, you can use it on a very basic system. So that's it for the presentation, and now I'll show you the live demonstration of the software. So this is basically the GUI of the software, and let me just show you. Yes. So if you want to import the DICOM images, so this you have to use this import button, and you can see you have the option to import directly medical images, which are basically in the DICOM images, and industrial images, that is the icon. And you can directly also import the basic image formats like JPEG, PNG, RAW, etc. And you can also directly import 3D models. That STL is the universal format for 3D printing or 3D, like if you're working in the 3D domain, so you can directly import the STL images. So right now, we have very less time, so I'll just give you a basic overview. So as you can see, these are the different section, and these are the tools which allows you to perform the different processes during the image processing or 3D printing. So when you are going to import the image directly from here, so you can see all these tools are basically arranged in a chronological order, because you are always going to process the image before segmentation. So that is why image processing segmentation section is the first tool. Like this crop tool or resampling tool is basically the first tool that you are going to use after importing the images. So these are the different views: coronal view, sagittal view, axial view, and this is basically the 3D view. So right now I have this image data of blood vessel, and you can see all different slices. You can scroll through the different slices of images. So right now I have a data set of 73 images. So these are some of the tools for image processing. Like you can select the region of interest out of this image data using the threshold values. Like this software utilizes a grayscale based value selection, and this is the histogram. So you can modify this histogram out into the the type of region. Like if you want to perform on the vessels, then you can adjust this accordingly. Also, this is the auto segmentation section, that we have discussed in the presentation, that it allows you to directly you have to simply just click on any of these presets and it will automatically segment the whole data set for you. These are the surface tools which allows you to refine the model. Basically, if you are looking to print this image or model further to the 3D printers or any kind of, so this surface tools are very useful if you want to post process the image data. This is the volume mesh if you want to generate the volume meshes out of these data sets, so you can use this section. For the measurements, as I've told you, you can perform some of the scientific measurements. So you can calculate wall thickness, contours, volume, surface areas, density. Like a lot of people are working on a lot of orthopedics, like I've come across the people who are working on the bone density, so you can directly import the uh, data set and perform bone density, mass density. All these things can be done using this measurement sections. This is the section for 3D printing. It allows you to emboss, like it allows you to some set. It provides you with some set of tools which allows you to modify the 3D model. Also, you can generate CFD model directly out of this software. And let me show you something. Also, it has a feature of live 3D. So basically, it allows you to for this feature you need to have a capable graphics card, but this feature is very useful for the people who are working in the field of medical, because it provides you with the real-time visualization of the model. Any changes that you are going to do inside any of your data set, it is going to reflect that in the real time. And this is vehicular dataset browser. It allows you to generate multiple mask models using like if you have the only this data set and still you want to generate the different mask of different regions out of it, so you have the flexibility of that. You can use this dataset browser for that. And that's pretty much it. Like this is the basic workflow of the software. Most of the tools are basically it depends upon your application area. Like if you are just working on segmentation part, then these 3D printing or other tools are like redundant for you. But uh, it's completely dependent upon your application area. So basically that's it for the presentation. If anybody have any questions related to anything for the software part, presentation part, feel free to ask me.
Thank you so much, Gaurav. And I think that was very detailed in terms of how software and simulation can really help in the process and also in medical. So, one question actually is, Gaurav, these softwares are also approved, FDA approved.
Yes.
If I'm not wrong,
Yes, sir.
so what does it actually do? As in, is it the process in terms of getting the finite required inputs, and what is the reason for this to get? I mean, I'm just trying to understand as a layman why the FDA approval is required for even softwares.
Sir, like It depends upon basically the first thing that it requires is the type of data set, although your application area. Not every person require that FDL approval for that. It depends upon your application area, that what you are going to do further with that 3D model or the data set you have. So, like, I'm not completely sure about this, but it is not applicable for every person who are working in this domain. It depends upon the type of application that they are working or the research field they are working. So that is very specific to their application area, not specific to the software. But I'll confirm it with the synopsis and I'll let you know about that.
Okay. So great. So thank you so much, Gaurav, for your inputs,
Yes.
and also Dr. Bikramjit. Thank you, Doctor, for your presence, and also Dr. Vikas and the other gentlemen. Many of them had to also plan the schedule accordingly, and so they had to leave after the presentation. So thank you so much for your participation, Doctor. If you want to make a last statement with your share of inputs. We will also be covering this entire 2-day program, and also be uploading it in our 3D Graphy news. For those of you who probably who have not known the structure, the 3D Graphy is actually got, it's a 360 degree. So we have 3D Graphy news, which is also an online news channel, where the larger intent is to try and communicate and source information with end users as well as technology companies and also researchers coming up with their inputs to share it with the end audience for them to take the best in terms of what is in terms of creating as a value, and also then to conduct these events. This is our 44th event that we have been able to conduct, and 23 virtual events for the last 2 years. And furthermore, we also have platforms like 3D Graphy Spotlight, where the conscious effort will be to discuss on one subject at a given point, with the company of expertise sharing those insights on the subject. So that is also something that we've designed. We also have something called 3D Graphy Shop Mart, because now that we know that there are technologies getting proliferated and many machines coming in the market, which is a good sign. We are also seeing that there's a lot of clutter happening. So there are end users looking at the right solution, maybe a doctor or a surgeon or maybe a dentist or an entrepreneur looking at these solutions. We have created a platform called 3D Graphy Shop Mart. So all those details are there in our platform that we've been able to design. So for people to visit, you are invited to go and visit the exhibition booth, the virtual exhibition booth, to get all these information. There are also some of the partners who are actually from 3D technology, whom you can connect directly. So towards the day, we are actually building this course. We have said 2,872 key respondents wanting to learn and understand the technology and the benefits. So thank you so much, gentlemen. And Doctor, if you want to share your inputs on this, please do. Thank you so much.